This is video number 10 in the cardiovascular series, and our learning objectives for this particular lecture are as follows. We want to describe the influence of stroke volume and heart rate on cardiac output. We want to define this thing called contractility, as well as ejection fraction, preload and afterload, and influences on preload and afterload. So up till now, we've looked at kind of the basics of things like SA node and AV node and depolarization of pacemaker cells, as well as ventricular myocardium and such. And now we want to look at the heart as a whole and look at how the heart actually, what it actually does meaningfully for the human. So we've got this thing called cardiac output. So let's move slides. There we go. Cardiac output. So what is cardiac output? Cardiac output is the amount of blood ejected by the heart per unit of time. If we back that up just a second, we might say, look, what does the heart do? Before you learn any of this cardio stuff, if anybody asked you, what does the heart do? You'd say, well, the heart pumps blood. At the very least, not even taking an A&P course, I know that the heart pumps blood. So the next question then is like, okay, so if we want to determine, whether or not the heart is doing its job well or not, what might we consider? And we could say, well, I guess if its job is to pump blood, we should consider whether or not it's pumping blood effectively. And okay, great. How do we measure that? Okay, let's do that per unit of time. Let's say under normal conditions, the heart should be moving this amount of blood. And if it's not moving that amount of blood in a given unit of time, then I guess it's just not doing a good job. And so the reason I say that is that I want you to have some degree of intuition for this term cardiac output and not just memorize things. So again, the amount of blood ejected by the heart per unit of time. Now, typically that unit is expressed in minutes. And so if we take another example, if we say, hey, how fast does this car go? Traditionally we express the speed of a car in miles per hour. If you wanted to, you could express it in minutes, right? You could say if it goes 60 miles per hour, then it goes however many miles per minute. You could do it per second if you wanted to, but that's weird, right? I mean, nobody really talks about how fast that car goes expressed as miles per minute. Nobody really does that. And so similarly, in cardiac output, you could express how much blood is pumped per second, how much blood is pumped per hour, per 24 hours if you want to, but traditionally we express that in minutes. So this is our standard formula for cardiac output. Cardiac output equals heart rate times stroke volume. So what I would encourage you to do right now is to stop the video, whip out a sheet of paper, and just write this out. Write it out algebraically. Say cardiac output, whatever that is, equals these two things. So if we were to do that out, I have that on the next slide. We'll go ahead and pause the video and make an effort at it first. And if you're coming back now after having paused the video, here's what you should have come up with. You should have come up with, well, something like this. You'd said, well, heart rate traditionally is expressed in beats per minute. Okay, that's again, how many beats per minute? And you know that normal in resting state, normal is about 60 to 80 beats per minute. So we'll just take a nice clean number and call that 70 beats per minute. And notice how I represent this as a fraction. Stroke volume. What is stroke volume? Stroke volume is the volume of blood pushed out per beat. Okay, per beat. Every time the ventricle squeezes, how much blood is being moved out. And we've seen that before on the pressure volume curves and the Wigger's diagram and things like that. So stroke volume is expressed in milliliters per stroke or per beat, right? And so what is that? Again, about 70 milliliters per beat. Of course, there's variability in here. We're just taking average numbers here for your so-called average human being. So if we do that, and again, it's a very simple formula. If we multiply the two, then we'll, if we look at that, the beats right over here in heart rate will cancel out with the beats here in the denominator over here. And so if those cancel out and then we look at the coefficient, 70 times 70 is 4,900. What we're left with is 7,900 milliliters per minute. So again, what is your cardiac output? It's about 4,900 milliliters per minute. If we round that up just to make the numbers easy to look at, cardiac output is about 5 liters per minute. That means 5 liters of blood is moved by your heart at rest per minute. Now, if you go back to what you already know about blood, you know that our kind of textbook number for the volume of blood that we have is 5 liters. So what this means then is that your entire blood volume is being moved by the heart in a single minute. And again, this is at rest. So now here's just a question to think about. Can cardiac output be changed? Can cardiac output actually go up under certain conditions? And you should think, well, I guess so, because if you're talking how much blood is moved per unit of time, then I know my heart beats a lot faster when I'm working out. And you're right, your heart is going to beat a lot faster when you're working out. And so what happens here? Let's see, heart rate would go up. Let's say instead of 70 beats per minute like you were at rest, let's say you're working out with a, I don't know, let's just say moderate intensity. Now you're going at 120 beats per minute. Well, then even if stroke volume remains unchanged, if you do the math out there, you can see certainly cardiac output would go up. Similarly, if we keep heart rate constant and stroke volume goes up, meaning that there's some sort of influence that says, hey, let me have the ventricles squeeze harder. And if they just squeeze harder, then instead of squirting out 70 milliliters per beat, now they squirt out 90 milliliters per beat. Well, of course, in that case, then cardiac output also would go up. Now, it is important to keep in mind, if we were to go back to this pressure volume curve that we've seen previously, remember that end systolic volume was 65 milliliters. Remember, that is the volume of blood left in the ventricle at the end of systole, at the end of its contraction. So what that means then is your ventricle is never really going to be empty, okay? So there's still some room left in the tank. If for some reason I'm exercising and I wanted greater fuel delivery, I could beat harder. My left ventricle here, once it begins this ejection component, I could beat harder, and instead of going from 135 to 65, I might go from 135 all the way down to, let's say, 55, squirting out an additional 10 milliliters per beat. The question should come up right now. If you're following with me, you might say, okay, well, that's cool, so I can tap into that, and so my end systolic volume might, in that case, during exercise, be 55 instead of 65. Well, what about this? Can I ever squeeze more blood in there? Can I have an end diastolic volume greater than 135? Some of these things we'll get into in future lectures. I just am trying to introduce the notion of cardiac output here. And the answer is yeah, of course. Okay, I shouldn't say of course. That's probably not obvious, but I will say definitely you can. You can increase end diastolic volume through a number of different mechanisms, which we will eventually get to. All right, so anyway, going back to the slide, there's cardiac output again. The two variables there are heart rate and stroke volume, and I just want you to appreciate that both of these variables, heart rate and stroke volume, they're both manipulable, meaning that we do have stuff in our physiology that can manipulate heart rate to modify cardiac output. We have stuff in our physiology that can manipulate stroke volume to, change cardiac output. All right. Another term then here is ejection fraction. Ejection fraction sounds like it's a whole altogether different concept, but really it's very, very similar. What ejection fraction is, here's the definition, is the fraction, you know what fractions are, a fraction of blood ejected by the ventricle relative to end diastolic volume. In other words, if I were to ask you, hey, how much blood do I move per stroke, then many of you would say, well, let's go back to this diagram that we've looked at so often, and this represents stroke volume, right? C to D. So 135 minus 65 is 70. So 70 milliliters is going to be stroke volume. And you'd be right. That's a great way to think of it. But then another way to look at that is then saying, well, I just don't want to know the quantity. I don't want to just know, how many milliliters it is, but I want to know relative to how much I've topped up. Okay, so relative to 135, what is 70? Like, what percentage is that? And again, this is meaningful because remember that end diastolic volume is also manipulable. We've got physiology where we can kind of fill up the heart more before it actually contracts. We've got physiology that can influence the degree to which the ventricles contract, therefore the degree to which blood is moved out, how much blood is moved out per stroke or stroke volume. So because all those things are manipulable, I mean, the raw numbers, the absolute numbers, 65, 135, 70 serves us well, but we also want to know kind of relative proportion, and that's where ejection fraction comes in. So it's the fraction of blood ejected by the ventricle relative to end diastolic volume. And again, this is recognizing that end diastolic volume is manipulable. So here's your very simple equation. Ejection fraction is stroke volume over end diastolic volume times 100. All right, so there it is. So we're going to take your stroke volume of 70, your end diastolic volume of 130, and I just chose 130 there. I know on this slide it says 130. Whoops. I know it says 135, but let's just go with it and just say potato for right now, for argument's sake. And so if it's 130, then if you do the math out, multiply it by about 100, that comes to about 54. And normal ejection fraction is considered to be anywhere within this range, 50 to 75. So ejection fraction is something that your doctors are also going to want to know about with respect to how is your heart functioning. So they don't want to just know how much blood is being squirted out, but how much relative to how much it filled up. All right, next couple of concepts then, preload and afterload. So preload is preload and afterload. Preload right here is left ventricular end diastolic pressure. Okay, so preload is another term that we use to say at the end of diastole. Remember, in diastole, I'm filling the ventricle with blood. At the end of diastole, what is the pressure inside my left ventricle? And so that term itself is going to be the preload, and that's going to influence something that we call the Starling mechanism, which we'll look at in a later video. Actually, will we look at it later? Let me just mention it now. What is the Starling mechanism? It is this mechanism that we see in the heart where the quantity of blood returned to the heart is the quantity of blood ejected by the heart, stroke volume. So what does that mean? Look, I just said to you, end diastolic volume is manipulable, right? So sometimes I fill the heart up with, let's see, I don't know, X amount of blood. And sometimes I fill up the heart. When I say this, I mean the left ventricle. Sometimes I fill the left ventricle with X plus 10 milliliters of blood for various different reasons out there. Well, the Starling mechanism is this thing that we have in our heart where whatever the quantity of blood is that's returned to the heart, whether it's quantity X, whether it's quantity X plus 10 or X plus 20 milliliters, whatever it is, that's the quantity that's going to be squirted out by the blood. That's going to be the quantity of the stroke volume. And you'll see that this is actually very, very, very useful for us because otherwise we're in trouble. In other words, picture the left ventricle filling up here with, 70 milliliters of blood. If it fills up with 70 milliliters, it better squirt out 70 milliliters. Imagine if it filled up with 70, but now it only squirted out 60. Okay, now it continues to fill with 70 more and only squirted out 60. It fills with 70 more and only squirted out 60. Over a handful of cycles, you'll see where that left ventricle gets really, really quite full and there's no room to receive blood anymore. So obviously that's not okay. On the other hand, if it fills with 70 and I squirt out 80, because remember I got a little reserve here. If I squirt out 80 and I do that for yet another cycle and then another cardiac cycle and another cardiac cycle, you're going to come to the point where that left ventricle is running dry and you've got like nothing in there anymore. And again, this is also not a desirable situation. And so for that reason, we've got this mechanism in place where whatever blood is returned to the heart, in other words, whatever blood fills up into the ventricle is going to be the amount of blood that gets squirted out, and that's our Starling mechanism. These things, again, are going to determine preload, which is left ventricular end diastolic pressure. Well, what is afterload? Afterload is this thing that is systemic vascular resistance. It's how much resistance the heart must overcome to open the aortic valve and push blood into the systemic circulation. What does that mean? Look, what is the heart pumping blood into? The heart is pumping blood up into the rest of the body. I'm looking for a slide here. If I can go back to some meaningful slide. I'm kind of going way back here in our lectures. So right over here, this left ventricle is pushing blood out into the systemic circuit. There's this term called resistance, which we'll look at in a separate series of lectures. And what resistance is all those things in these pipes that oppose the movement of blood. I'm not saying it's an intentional opposition. I'm saying there's just some resistance. Look, when you go out for a walk around your neighborhood, there are things out there that are offering resistance. And this is why your muscles have to work. Gravity is offering you resistance. Gravity is giving you a certain amount of resistance that your body, your muscle must overcome to move forward. Friction on the sidewalk, a little bit of a wind in your face. These types of things all offer resistance. Similarly, there are different variables out here in the systemic circulation that are going to oppose the movement of blood coming through. And broadly, we call that peripheral resistance. Now, your heart needs to generate enough pressure that it can overcome that resistance, just like you need to generate enough, I'll just use the word pressure very loosely now, when you go out for a walk to overcome the resistance of gravity and wind and the friction of the sidewalk and whatever else might be there, all right? Otherwise, you just don't move. You're just kind of stationary. So similarly, the heart needs to generate those forces. And those forces broadly, right, when we cluster them all together, I know I haven't broken them down into, well, what are those forces that are resisting blood flow? I haven't done that yet. I get that. But those forces in aggregate are termed afterload. This is systemic vascular resistance. And hopefully it makes sense that whatever that force is that's pushing against that blood, so to speak, then the heart needs to generate more force. This is why from the very beginning we've said things like the job of the heart is to generate a pressure gradient. It's got to generate more pressure to overcome that vascular resistance. I took this from somewhere online, 2007 Nursing Education Consultants. I don't necessarily want to talk about this, but if you want to go ahead and freeze the video to try to make some of this stuff make sense, or Google this yourself, Nursing Education Consultants, and wherever I got this picture from, then it may be worth your while. But preload and afterload, I think I've defined them sufficiently for what our goals are in the course. Now, The last couple of concepts are these. We have these things called inotropic influences. We have these things called chronotropic influence and dromotropic influences. Now, ino here refers to ions, sodium, potassium, stuff like that, calcium. Chrono refers to time. Dromo refers to conduction velocity. So we have these things out there in physiology that can make the heart beat harder. We're going to talk a lot more about these down the roads, but these are things that alter cardiac contractility. Contractility is just a fancy word that says how hard does the ventricle squeeze? Does it squeeze like, medium hard or super hard? How hard is the ventricle squeezing? You can imagine then that how hard it squeezes is going to influence stroke volume. And so we have these things that alter cardiac contractility. The positive inotropes, these are things that increase calcium availability within the heart muscle itself. These are catecholamines like epinephrine, norepinephrine. So if we take a step back, what are we really saying? Sympathetic stuff, fight or flight. Sympathetic stuff, fight or flight, makes your heart beat harder. And that should be consistent with what you know. On the other hand, there are things that decrease calcium availability within the muscle fiber cell itself, and those are things like acetylcholine. The question I put here, does vagus nerve innervate ventricular myocardium? I don't know that we've seen that yet, but I'm going to say no, it doesn't. But acetylcholine experimentally is known to be have a negative inotropic influence on the heart. So these are inotropic influences. Now, if you Google this stuff, you'll find laundry lists of different medications, drugs and stuff like that can be used to have either positive or negative inotropic effects. All I've included here are just the normal physiological things, because we're looking at physiology, not pharmacology, okay? But there are definitely a ton of things out there. In fact, most of the time when people are talking about inotropic influences, they're really talking about it from a clinical management standpoint. And so you're going to see a whole bunch of different drugs out there, all right? Here is just a nice little slide showing us that norepinephrine, it increases heart contractility because of a second messenger system using cyclic AMP. So we don't need to rehash the second messenger system, but remember that the G protein's involved, there's adenylate cyclase, and so on and so forth, all this stuff. But ultimately, what do we see? We see an increase in calcium release. And when you see an increase in calcium release right here into the cytoplasm, that's going to enhance actin-myosin interaction, which will increase cardiac contractility. Now, then the last slide I want to show you guys is this one, how to make the heart beat faster. So here we're looking at inotropic influences that make the heart beat harder or less hard. Here, what are the things that can make the heart beat faster or slower? I guess you can also put slower up here in the title. And these are chronotropic influences that alter heart rate. Well, what are the positive chronotropes? They increase heart rate, and these are things like epinephrine again, and negative chronotropes decrease heart rate through acetylcholine. Now, recall that the vagus nerve does influence the SA node, right? There's direct innervation of the SA node, and so there definitely is physiological acetylcholine that's dumped on the SA node when we want to slow down heart rate. I want to take a moment here just to remind you, when you slow down heart rate, what does that do to cardiac output? Well, if you slow down heart rate, assuming stroke volume is unchanged. That's a big assumption, but just for argument's sake, assuming stroke volume is unchanged, but you slow down heart rate, what happens to cardiac output? It'll go down, right? And does that make sense? Well, where do we see acetylcholine? As we see acetylcholine, again, through the vagus nerve, which is a parasympathetic thing. So under parasympathetic conditions, do you decrease heart rate? Yay, of course you do. So a negative chronotrope. And then dromotropic influences. These are things that alter conduction velocity through the AV node. Remember that the AV node itself is kind of holding that charge just a little bit? Well, that is also manipulable. And so we can either increase conduction velocity through the AV node through, again, epinephrine, or we can decrease conduction velocity, again, through acetylcholine. So if you look at these are all the same, right? Epinephrine, acetylcholine, and with the inotropic influences, again, epinephrine and acetylcholine again. And again, shouldn't be a surprise because epinephrine we associate with sympathetic fight or flight responses, and acetylcholine we associate with parasympathetic rest and digest responses. This is our summary slide. We've looked at all these terms, stroke volume, heart rate. We define contractility. And we recognize that contractility directly relates to stroke volume. If contractility goes up, stroke volume goes up. If contractility goes down, stroke volume goes down. We define ejection fraction as that essentially stroke volume relative to end diastolic volume. We talked about preload, afterload, and those variables that might influence preload and those things that might influence afterload. Well, I guess actually number 5 and 6, I only broadly talked about them, but we will hit those a little bit harder in later lectures. All right, that'll wrap it up for lecture number 10.